Influenza, it's kind of a hot topic right now. I had 2 kids the other day, yesterday, in the ED with influenza. We've seen a ton of it in the last 3 weeks. We had a really mild season this year. But before I went to PA school, I was a high school history teacher for 6 years. And so if any of you guys know about the Spanish flu pandemic in 1918, 40 million people, that's an estimate. Some estimates go up to 100 million people died from influenza in 1918. More than were lost the entire 4 years of World War I were died in 2 years of the influenza epidemic, or pandemic. So we lost almost 700,000 people in America to the influenza pandemic. We only lost 53,000 in the war. So when a pandemic, I mean, if you guys remember 2009 with the H1N1 and all that, it's why the WHO and CDC takes these pretty seriously. You hear about the Black Death. Well, more people were wiped out in 1918 from influenza than the entire Black Death, the entire bubonic plague. So why was it called the Spanish flu? Why was it called the Spanish flu? Anybody? It came from Spain? So that's the trick, right? It didn't come from Spain. In the middle of the war, Germany was hit the hardest, and Italy was hit really hard. But in an effort for propaganda, they didn't want to release their death numbers. Spain was neutral during the war. So Spain reported true death numbers into the tens of millions of affected people and several million dead. So even though it started in Germany, it was actually called the Spanish flu because they were neutral. They could report without, Germany loses 2 million people. Oh, prime target right now. So you see this is the one of the posters from then, and it references the poison gas that was used in World War I. Influenza is more deadly than the poison gas, the mustard gas. This is, you can see the life expectancy that happened over 3 years. We lost almost 20 years in the life expectancy during those 3 years of Spanish influenza. So this is a poster from a theater in Chicago during that time. If you cough or sneeze, you'd be kicked out. The usher would come and get you and take you out right then, quarantine you. So this is one of the little rhymes the kids used to skip to on the jump ropes in Chicago. I had a little bird, his name was Enza. I opened the window at influenza. Yeah. So it actually goes further back, because this is one I found from 1894. This is a long poem, and then kids adopted it to jump rope to. So influenza, we go about every 7 to 10 years having a major pandemic. So let's see, 2009, we're set for one next year or two. Most of them are in 3 genres. So, viruses. Remember King Paul cried out for good soup. Remember all that from basic biology, kingdom file. Viruses aren't put into kingdoms. They're not truly living organisms. But they are classified based on their phylum and order and all that. And they all come from Orthomyxoviridae, which is the main, this is going to be your test, Orthomyxoviridae. You got to spell it too. Orthomyxoviridae. They all come from this one class, or one family. And the only 3 that we care about are A, B, and C. And they're different genres. And so we do that by the inside. We put them into families by what's inside them. And we'll talk about H1N1 and H5N1 and all that. That's based on their outer proteins. But they get put into families based on the inside stuff. So it affects about 3 million people a year, and somewhere around 500,000 deaths per year in bad years. Now this has been a really nice year. Last time I checked, there were under 100,000 deaths worldwide in this whole flu season. So the flu season starts in June worldwide down in Australia and all that, and in the Near East moves over. So by the time it finishes, it's March here or so. And there's been about 100,000 this year deaths. So we haven't heard much here, but it's pretty good. On average, about 5 to 10 to 20% of people in the U.S. will be affected by it. We'll have about 200,000 hospitalized, and another 35,000 will die in the U.S. This has been a really mild year. It's under 20,000 have died this year from flu-related illness. Now, of course, you guys know the extremes of age, the little kids, the old people, the diabetics, the immunosuppressed, the HIV, all of those things. There's a few that we'll talk about that really hit us, and I say us because I hope I'm not that much older than you, the middle-aged, healthy population. We'll talk about which ones those are. Of course, you guys know what it looks like when you sneeze, so please don't sneeze on me. I've been healthy this year. It's an aerosol transmission for the most part. That's when it's most infective, when it comes out of your lungs and goes into somebody else's. But it can be held on fomites, on inanimate objects for days. It takes a temperature of about 130 degrees to kill it, and it takes an hour for it at 130 degrees. You can kill it using a very acidic solution, so very acidic pH of less than 2. And of course we know that the survival is aided by UV radiation kills it, so no UV radiation and a low humidity, which sounds like winter, right? That's perfect for the flu. And you're most infected on the second and third day, but that's when you start showing symptoms. So you're actually infecting people when you don't know it. So everybody stay home tomorrow. So influenza A, that genus has one species. I mean, it's hard to keep track, I know, of this stuff, but there's only one influenza A. Wild birds, ducks mostly, are the harbor of it. But it can infect everybody through genetic drift and genetic mutation. So it goes from a duck to everybody else, swans, geese, things like that, to swine, to us. It's by far the most virulent of the three types, influenza A is. Causes the most severe disease, and it's usually the reason we have pandemics and epidemics. Here's the life cycle real quick, from the wonderful waterfowl into more common domesticated fowl like chickens on farms, things like that, or into swine, which we love to eat both of those, right? Pork and chicken, you know. Second one is steak in Oklahoma. Yeah, bacon, right there. Bacon's gonna kill you one way or the other. So H1 or flu is classified based on your body's reaction to the outside of the virus. So it has hemagglutinin and neuraminidase on the outside of the virus. How your body reacts with the antigens you make is how we classify it. So there's 17 H types, 17 hemagglutinin types, and 9 neuraminidase types. So each one gets a name depending on which one's coming up that year. H1N1 2009 was the big one. It's also the cause of the Spanish flu. H5N1 is the most serious threat we have today. Luckily, it hasn't really made the jump into humans through that genetic mutation. It's still mostly in chickens and in waterfowl, but it's the one we're most worried about, the avian flu. And we'll talk about why in a second. There's a few, if you handle fruit bats in Guatemala, black-headed gulls in Norway, you probably need to be checked for age 16 and age 17. There's been no human deaths from either one of those. So you see that some of them just stay in the animals and never infect humans. So this is a real quick look at where they are. What do you see that's in common for every one of them? That's in this column.
Birds.
This column. Yeah, birds. Stay away from birds. I hate birds. Stay away from birds. Right? Never had a parrot. My kids want a parrot. No way. I don't want to get H17-1. So stay away from the birds. That's the big problem, right? Influenza B, there's only one subspecies of influenza B, and that's influenza B. It affects humans almost exclusively. It's not really carried by swine or birds. And it's far less virulent. Usually we've all had influenza B at some point. If we get it again, it's a pretty mild disease. We get some immunity early on. So if we get it again, you usually have a less temperature, you don't feel as bad. Somebody checks you and, oh, you're influenza B positive. Influenza C has one species, it's influenza C. And it's very mild, never been reported to be epidemic or pandemic. And you can't even test for it. If we test for it in the office or the ED, you get A and B, you don't even get C. It takes a special lab to test for C just because we don't care about it really. It just is not virulent, it doesn't bother you. It's got a very fast life cycle. By the time you get it, it's almost dead in you. So, as we talked about, all three of them are about the same. You see on the outside you have the neuraminidase and the hemagglutinin proteins. That's what your body reacts to. And that wraps around the genetic core of RNA usually. All these orthomyxoviridae are all RNA viruses. And the difference, though, is how these affect you. So you'll see that the H1N1, which 2009 and all that, mostly affects the upper airways, the upper respiratory system. It's easily spread, you cough, it's spread, but it's rarely fatal unless, as we'll talk about, you have some other problems. The H5N1, the one that we were worried about in birds becoming a pandemic, you'll see that it concentrates, first of all, it's much slower to develop and spread. And so you walk around longer with it, and it's more often concentrated in the lungs. So, real quick, the biggest problem, people die from influenza because of two issues. First of all, their adrenal cortical system gets shut down. It inhibits ACTH, which lessens your stress response, right? We know this pathophysiology. No ACTH, no cortisol, no catecholamines, and so your stress response is terribly blunted by these. That's why the young and the old are really most susceptible, right? You can take, just as a general rule, you take an old person's temperature. A lot of times they won't have one, and they'll be pretty infected with UTIs, pneumonia, because they just don't mount that stress response. Well, it's even further blunted with influenza. The ACTH is really blunted. So the other problem, the one that we see with the H1N1, and these have become pandemics like the Spanish flu, is it affects younger people through a cytokine storm, right? You have over 150 cytokines, those pro-inflammatory complexes you need. Influenza activates your body to overproduce these cytokines. And you get what's called a cytokine storm. And the worst place is in your lungs. So you have this massive influx of pro-inflammatory molecules that fills your lungs up with fluid. So it's actually worse to be a healthy person with a good immune system during H1N1. Your body overreacts to it. You have a cytokine storm. We'll talk about that more in ARDS too, these cytokine storms. And then of course you get secondary viral pneumonias, you get ARDS, we'll talk about that. But the two big ones to worry about are the stress blunting and the cytokine storm. So you guys should all, if you haven't had influenza, you should try it once. It's something you'll never want again. The abrupt onset of fevers, usually 39 to 40 degrees Celsius, even 41 degrees Celsius. And it's an abrupt onset, right? That's how you differentiate it from the cold. The cold takes a day or 2, 3 days. Fever, you were like, I was walking down the street and then a bus hit me, I don't know what happened. I have 103 fever, I'm shaking, I can't stop shaking. I have a cough. The GI symptoms, I have extreme fatigue, I can't get out of bed. The GI symptoms are not a real problem, except in kids. For some reason, it disproportionately affects kids' GI system, especially with diarrhea and nausea. So cold or flu, we just talked about that. The flu has extreme fatigue, it's an abrupt onset, and for the most part, you lack the GI symptoms. So, what can you do? Well, the best thing you do is get immunization to prevent it. An ounce of prevention is worth a pound of cure, right? So it's always recommended for those high-risk people, the elderly, the infants, the pregnant, immunocompromised, diabetics, asthmatics, those kind of things. And we know that for the most part we make trivalent vaccines, right? They take the 3 that are affecting Australia, the 3 that are affecting China and Japan, and we figure out which ones are going to be deadliest to us. We put them in a cocktail, we give it to you every month, every year. And it's highly effective usually. Sometimes we screw up, there gets genetic drift, and it's not quite the same one that affected the Far East or the Near East, and so everybody yells about it. It's worthless. But it's not, we know that it really works. It's really good at preventing the flu. It's probably the only thing you can do to prevent it. And most of the ones you're going to get in the arm are the inactivated one. So they either do subunits of the protein capsid, or they do a split virus. They grow it in a chicken. I know, see chickens, they grow it in a chicken and then split the virus, they kill it, and they purify it and give it to you. There is, in the last 5 years, the live attenuated, right? Attenuated means decreased power, decreased strength. So the live attenuated vaccine, which is the intranasal flu mist that you can get now. So that one, right, everybody says, oh, every time I get the vaccine, I get the flu. No, you don't, unless you get the flu mist. Then you can actually get the flu if you're a young, healthy person who's got a great immune system. It just happens. Right? Everybody used to get sick a few times a year, not be so healthy. The H5 vaccine, the H5N1, the bird flu we're so worried about, there's no vaccine for it. So these vaccines are all cultured in chick embryos or chick eggs. Well, the problem is it lyses those eggs, and it lyses the host. So a vaccine's been really hard to make for the H5N1. There's also quite a bit of genetic drift within the H5N1. So, yeah, you can't get them immunized against the H5N1 bird flu yet. They're working on it. There's actually something in clinical trials right now. They're using something else as a host. It's not a chick, I forget what it is. But we're not there yet. So what can you do to cure influenza? Nothing, absolutely nothing. There's M2 protease inhibitors. Those are the adamantines, which is not what Wolverine has for claws or Captain America has for a shield. Right? It's adamantium. I love superheroes. I have 4 kids. So, now I can't say the right one. Amantadine inhibitors, are adamantine inhibitors, like amantadine, which we don't use much anymore, or rimantadine. Those are two of the older antivirals that really kind of fall out of favor. They block the M2 subchannel, so that the virus can't get into the cell. Remember, the virus has to go in the cell, inject a little protein, the cute little picture we all saw of the alien that injects, things back in biology. So it can't even get into the cell using these M2. The problem is viruses have kind of found a way around that. They use other subchannels. And influenza B doesn't even use the M2 subchannels, so it doesn't even matter. So what we use now is neuroimidase inhibitors. And those are Tamiflu, right? I'm sure you've seen the commercials every 10 minutes on TV right now. Or Relenza, which I don't know why Relenza doesn't spend more money. It's actually pretty effective, more effective than Tamiflu. And these stop the virus from getting out of the cell. Right? So the virus goes in, it replicates, it lyses the cell, you spill out viruses. So these stop the virus from being from lysing the cell and escaping the cell. So that's the mechanism of action that's been told. So we'll talk about why this isn't really true. If you know anything about the Tamiflu controversy, when it first got approved, Roche, the manufacturer, did about 40 different trials, and they submitted 2 of them to the FDA for approval. Right, so it's 38 that didn't get submitted to the FDA. Every time you do a trial, you do patient-level data. So we give you the drug, we give you the drug, we give you the drug, and you're patient A, B, C, and we de-aggregate it and report it. But somebody somewhere has the data for patient A. They took 150 milligrams twice a day, 150 milligrams once a day. Didn't take anything. We have that patient-specific data every time you do a trial. It just gets de-aggregated when you go to the FDA. So a couple years ago, the Cochrane review, Cochrane collaboration, about them? Evidence-based medicine. Don't use that anymore, anecdotal. So the Cochrane review is a great evidence-based group in the UK that does reviews. They do meta-analysis, they do independent reviews of trials. They're fantastic, they're great to use. A couple years ago, Cochrane said, hey, we want access to your patient-level data. Every patient that was enrolled in the trial, what they got, what the outcome was, and all that. And Roche said, no, we don't want to do that. And they fought that for years. Now, luckily, the EDA, the European Drug Authority, finally got them to turn over patient data. So they started doing more trials on this stuff and realized that Tamiflu really, originally the benefit was 2.5 days faster. The prophylaxis was great. If you took it, you wouldn't get it from your neighbor. If you took it and you had asthma, you wouldn't be hospitalized for pneumonia. This is all the stuff that Roche said originally. So Cochrane took a look at it, and this is what they found out after looking at all 40 trials, patient-level data, that oseltamivir, Tamiflu, did not affect the number of hospitalizations. If you got the flu and got Tamiflu, you were going to go to the hospital one way or the other. So, see, we're looking at all patients enrolled in treatment. We found out that oseltamivir has a lot more side effects than were originally reported. So, including serious heart arrhythmias. So, it was actually a little cardioprotective. You might not have an MI while you had influenza, but you might go into AFib, A-flutter, or even VFib, which, if you know, those are not good, especially the VFib one. And we saw that with adult treatment trials, it did not significantly reduce complications. So if you got it, you still got bronchitis, you still got pneumonia, you still got the other secondary infections, ARDS and sepsis. So here's why it's a good and a bad investment for you. It's a good investment if you own stock by Roche, right? The United States purchased 120 million doses of Tamiflu to stockpile. Okay, in 2009, or 2010 actually, after it came out, after the H1N1. Switzerland stockpiled 50 million doses. That's more than people are in Switzerland. Okay, so if you own stock by Roche, okay, If you are taking care of yourself or patients, probably don't use it. So you can see that the mechanism of action, that it stops the virus from escaping. Cochrane found no evidence that it actually does that. Their line is, statements made of the capacity of oseltamivir to interrupt viral transmission and reduce complications are not supported by any data we have been able to access. I work in the emergency room, everything goes fast. You have to be fast, so keep up. You guys don't read this anyway. The mechanism of action, which was proposed by the producers, does not fit the clinical evidence. So they found no evidence of reduced viral load in patients who were getting Tamiflu. So oseltamivir and zanamivir have small non-specific effects on reducing the time to alleviation of influenza symptoms. But we don't know if they reduce the complications. And the use of oseltamivir increases the risk of adverse effects such as nausea and vomiting. So if you're a kid and already have nausea and vomiting, that's a wonderful thing to have. You get more of it. Psychiatric effects, we know there's over 100 deaths in Japan associated with Tamiflu in kids. So adolescents and kids who took Tamiflu actually killed themselves. And renal events, including acute kidney injury and including need for dialysis. Like I said, great if you own Roche, not so great if you want to take it. So you guys should know NNTs and NNHs, right? Number needed to treat, number needed to harm. So there is no NNT. The Cochrane collaboration could not come up with an NNT, a number needed to treat, because it didn't stop the complications. It didn't reduce hospitalizations. So they found that it actually helps about 0.7 of a day. So Tamiflu this year was about $168. And you can reduce your symptoms by 0.7 of a day if it's treated within the first 24 hours. After 48 hours, it's less than half a day. So, if you wanted 16 hours of better living, then Tamiflu. And you have $168, that's fine. The number needed to treat for prophylaxis, for being able to, so you have Tamiflu, I give it to all your kids in the family so they don't get sick. You need to treat 13 people, close contacts, to prevent 1 case of flu. Okay, so that's fine. If you want it 168 times, I don't even know. The number needed to harm, though, was 14. So over 14 people that are treated, 1 is going to have worse vomiting. Okay? Again, great for kids, right? I mean, they're already sick, they're already puking. Let's give them something to help more. And then for slight disturbances, this one bothers me the most, it's 19. So for every 18-year-old and below that you treat, for 19 of them, 1 will have a notable psychiatric change, and 1 out of 33 will have a severe psychiatric change. That can be defined as just insomnia. It can be everything to psychotic break or suicidal intentions. So, I think I've written for Tamiflu about 6 times in the past 8 years. And those were people who were severely sick, leukemia, things like that, or I was put in the hospital for severe problems. And I figured they couldn't get any worse than going to the hospital. So there is a new one, lenacapavir, which they just keep making things longer names. It's a neuraminidase inhibitor also. It's still in trial, but according to Cochrane reviews, they got some pre-released trials. It appears to have less side effects. It appears to be able to lower the viral load and transmission better. So it doesn't have a real name like yet. We don't have a fancy name like Stop Flu or something like they call it. But it's in the pipeline. It's in phase 3 trials right now, so we'll see. But of course, this is what Tamiflu said before they got released too. So what are your real treatments? Well, it's not too hard, right? Take antipyretics. Take your favorite antipyretic, ibuprofen, Tylenol, aspirin, except if you're a kid, right? Don't want to get dry syndrome. Take plenty of pain medicine. Sometimes you'll need prescription pain medicine because the aches, the pains, the myalgias, arthralgias. Rest. Plenty of fluids, because when you have a fever of 104 and you're breathing 26 times a minute, you lose a lot of insensible losses, so replace those with fluids. Stop smoking if you're smoking already. We know that contributes to a higher secondary outcomes. Any pregnant person should be treated, and if you have it, you should avoid pregnant people. Of course, good hand hygiene, we know that. Seclusion if you have it. Don't go to the theater in Chicago, they'll kick you out. And then hospitalization for those that are the sickest. And that usually, remember, the sickest can be young and old, or it could be middle-aged, right? So the H1N1 disproportionately affects us, young, healthy people. Avoid antibiotics. We know that there's worse outcomes if you give antibiotics for a viral infection. The side effects, the number needed to harm for antibiotics in the flu is 12. So you treat 12 people with antibiotics. You'll have one case of a rash, anaphylaxis, diarrhea, pseudomonas colitis, C. diff, something like that. So avoid antibiotics unless you have a radiographically proven pneumonia or a culture positive sepsis, something like that. And then they did Cochrane collaboration did a huge study of steroids and found no benefit. They were trying to boost your endogenous steroids get pushed down, and so they were trying to boost that by giving you exogenous steroids, right? It didn't help at all. In fact, there were more complications actually. So that's influenza. We try to go through it fast because we have 2 more kind of lectures to go through. But any questions about influenza? Shouldn't be anything new that you guys haven't heard of. Anything about influenza? Has anybody had influenza this year in here? You guys been pretty healthy? That's good. I've missed it for the last few years. I had one. My wife had it when she was pregnant. It was horrible. I mean, it was horrible. I'm pretty heartless anyway. I mean, you do emergency medicine, you get pretty heartless. But it actually was really bad. I felt bad. I took a couple days off from my wife, and she was horrible. And my kids all had it. I didn't care less. I tell them, you know, you're going to die. No, you're not. It's this kind of thing. So, but we haven't had, none of our households, I have 4 kids, so it's like germ city. And they're all like, little knee biters. So we haven't had it, and we haven't had any of those outbreaks in a few years. We've been lucky. It's been a nice couple of years for influenza. So we're due for a bad one here in a couple of years. All right. Have you guys had any ABG work?
Yeah,
Or your own guess?
This morning.
Wow, that was
This
an
morning.
uncomfortable laugh. Okay, so you haven't practiced it really then. You've gone home and done 50 problems. Okay, you guys understand the basic, you understand Henderson-Hasselbalch equation?
No.
From under.
Whoa.
Okay.
That's
That's the one where it goes back and forth.
Okay, so you,
Hopefully that's right, because it's on the recording.
right, so the Henderson-Hasselbalch can be done really easily.
Okay.
That
West.
pH, I'm not going to go through the logs, right? You get the pKa minus the log. No. I'm making it really easy. I hate pathophys, I hate math. I taught history, not math. So you get the base over the acid. I also didn't teach handwriting. So base over the acid. If you get rid of this is like 6.1, the log of 10. So I don't care. So the pH, all right, this is what you have to know. The pH is your bicarb or your base over your CO2. That's a rough estimation. Because if your bicarb goes up, what happens to your pH? It goes up, right? You have more bicarb, you're more alkali. If your CO2 goes up, your pH goes down. Right? This is the easiest thing in the world. This is the Henderson-Hasselbalch for dummies, which is me. This is why I do emergency medicine. You don't have to think a lot. Stick tubes in people. So this is all you have to know. That the pH is going to be influenced by 2 things. It's going to be influenced by how much base you have and how much acid you have. The base we're talking about is bicarb, and the acid CO2. Okay? Really simple, because there's like 5 problems at the end of this stuff. Don't go ahead and start working on it. All right, so we intubate a lot of people in the emergency room. We intubate a lot of people in the ICU. We stick tubes down their throat, right in their lungs. Hopefully it goes in the right place. That's an example. This is actually one of my intubations from a couple years ago. Caught on camera with a glide scope. That's the good thing. You go through the vocal cords. Don't miss the vocal cords and intubate the esophagus. That would be bad. So we do it for 3 reasons. To protect somebody's airway, right? Like this poor gentleman who got gored in the mouth with that bull. He's going to have some airway swelling. He's going to have some stridor. He can breathe perfectly fine, but we're going to protect his airway, okay? So anaphylaxis. I had a poor lady with anaphylaxis the other day, and we don't know what to, but her airway started getting swollen. We intubated her. She was talking, well, she was mumbling. We intubated her not because she couldn't breathe, but because she was getting airway issues. You can have difficulty oxygenating, so delivering the oxygen to the blood, and that becomes alveoli damage like neonatal hyaline membrane disease, right? You guys covered that already? Neonatal distress, hyaline membrane disease, all that? Okay, great. Is this the first week of fall or something?
Well, we're doing like
Oh, spring, you slept since then, okay. It was spring break, yes, you stole a flag.
Neonate is on the next test.
Yeah. What?
It's on the next palm test.
Neonatal stuff?
Yeah.
Oh, okay.
So we're not
Drank, you stole a flag, I know, it's spring break. So, so you have difficulty delivering the oxygen to the blood, right, through the alveolar complex into the blood. Those people are working too hard, it's too hard for them to breathe, they get tired, so we help them with that. Or you have difficulty with respirations, actually breathing. So COPDers, little kids, they get tired. Myasthenia gravis, Guillain-Barré syndrome, those things that affect your breathing. So we take over the work of breathing for people, and we breathe for them. So one of 3 reasons to intubate people. It's not just for fun, it's not because the person is drunk and disorderly, which all the nurses want you to intubate people for, so they'll stop having to mess with them. People that are intubated can't talk, it's great. So remember this. What movie is this?
Princess Bride.
Best movie ever? Later we'll do lines from it, we'll go back and forth. So a ventilator is a simple machine. It's a bellows. You pump air into the lung. It's not hard. Everybody gets freaked out by these big ventilators that have 20 dials on them and numbers and it beeps a lot and it's not fun. But a ventilator is really a simple machine. You can squeeze the bellows faster, speed up the respiratory rate. You can squeeze the bellows deeper and give them more oxygen at a time, or you can squeeze it harder and pump pressure through their lungs. And that's all a ventilator does. It's really simple. It really is. And everybody gets scared by it. So hopefully you've talked about some of these terms before. We know that tidal volume is the amount that goes in per breath, while minute ventilation is what? Tidal volume times breath per minute. So if I'm ventilating somebody at 500 cc's, 12 times a minute, their minute ventilation is 6 liters, right? 6,000 cc's, 6 liters. FiO2, so you take the ventilator, you plug it into the oxygen, right? That would be the bad thing. It's happened before where the ventilator wasn't put on oxygen and they were just getting room air or less. So you plug it into the wall. You then dial up the FiO2. That's the inspired fraction of oxygen. So typically we start at 100%. 100% of oxygen, right? What's atmospheric oxygen? 21, right? We're going to go 21 because we like to round. You put them on a ventilator, they get 100% right away. Okay, start there. PEEP is a positive end expiratory pressure. If you measure the pressure of the alveolus, at the end of the expiration you get PEEP. BiPAP is something we use prior to or with ventilation. We try and save people. Some people are on it at night for sleep apnea, right? So it's bi-level. Their PEEP is 10, and their IPAP, their inspiratory pressure, when they're breathing in, is 15 or 12. So they always have some pressure in the airways to keep open the alveolus. So then CPAP is continuous. There's no EPAP and IPAP or PEEP. There's just a continuous pressure. You can think of CPAP as being the dog as you put your head out the window driving a car. It's just like constant pressure coming into your mouth. If you've ever seen somebody on CPAP, they have the mask on, their cheeks are doing this because you're blowing in 10, 20 cc's of water against their breathing. I used to work in the middle of nowhere in New York, in the Adirondacks in the middle of nowhere. And our crews didn't have CPAP or BiPAP to transfer, they were all volunteer crews, EMS. I wanted to transfer somebody from where I was, Albany or Syracuse or Buffalo. I had to intubate them and put them on a ventilator because they didn't have CPAP and BiPAP, the simple machine. And I literally joked, just stick their head out the window the whole time you drive and drive fast. It'd be better than me intubating them. But that's what you can think of CPAP for. It's just a constant breath coming into your face to open up your airway. You should know SaO2 and SO2 from this morning's ABG lecture. The arterial saturation of oxygen. It's a derived value for the most part. You get an ABG, it's a derived value. We don't measure the actual arterial oxygen. We derive it from the PO2, the partial pressure of oxygen, and the FiO2, what they're getting into them. So we can estimate what their arterial saturation is. It's usually pretty close to an SpO2, the finger monitor that you put on. The SaO2 and the SpO2 should be pretty close. And it's just a measure of how much of hemoglobin is saturated. PO2 is oxygen, PCO2 is carbon dioxide. Pretty simple. Until we get to the cases, then we'll see. All right, so there's two things you got to think about. The trigger and the target. That's it, trigger and the target. Who breathes and what are they breathing? How much are they breathing? So you have an obtunded patient, head injury, the person is septic and they're breathing 60 times a minute, the kid is, or 40 times a minute for adult. They've been doing this for 2 days, they're getting tired. Their myocardial oxygen demand, their oxygen demand is going up, their lactate's going up. You want to take over and vent for them, okay? So that's one, is we are the person who breathes for the patient. The other one is like the anaphylactic patient or the gourd matador. He can still breathe, his brain's working, his lungs are good, his neurologic system is good, he's not been breathing hard for days. They can breathe on their own, they just need to protect the upper airway. So as people are coming off the vent, this is the same thing, right? They're waking up, they're getting better, we transition to another mode. The two modes, there's three modes, but two you have to worry about. They're AC, that means we take all control. So think about it that way, it's actually assist control. And we set up every parameter of their breathing on AC. Or there's SIMV, and we don't use all those words, synchronized intermittent ventilation. SIMV. And then the breaths are controlled by the patient, and the machine helps. There's also some pressure support, pressure control, all these other modes. The two that we worry about are AC and SIMV. Okay? So in AC, the patient does nothing. They're sedated, they're paralyzed usually, they're on propofol or one of these kind of things, ketamine, whatever it is that you're going to use to keep you down. And the machine does everything. So if you set it to 20 respirations, they're going to get 20 respirations. If their tidal volume is 600, they're going to get 600 cc's. Okay? So the problem is if you're over-breathing, right, you're blowing off all your CO2, low CO2, pH goes up. They get alkali sometimes. If you don't have it turned up enough, and you've forgotten, left it on 4 or something, for some reason, then they get acidic. They hold on to their CO2, and they get more acidic. So the other problem is, we'll talk about breath stacking in a minute, but it can lead to lung injury and a pneumothorax. So all ventilators have 2 loops. Green, I feel like I'm at home with my kids. I get all the colorful stuff. All ventilators have 2 loops. You have an afferent and an efferent loop. So you have the vent, and then you have the patient. Taught history, not art. So the afferent and efferent loop. So you're delivering oxygen to the patient, and then the ventilator senses what's coming back, and the pressure which is coming back. So every time you take a breath, and then breathe out, it measures what's being sent back. So my goal is to send in 500 cc's. I should get back somewhere around 475 to 500. I should be exchanging that. And the ventilator knows that, it senses that. Okay? So this is really important in the SIMV modes. Because this is an open, did I just change that? Sorry. This is an open loop, right? It's an open system. It goes in the lungs, it comes out, and it's an open system. When the patient takes a breath, this loop is broken for a second. That constant 500 cc's is broken for a second on SIMV, right? Because we're not breathing for the patient, there's just air going through the loop. When they take a breath and the machine goes, oh, there was an interruption of the cycle. The machine then breathes for the patient. It helps the patient breathe. Okay? So if it doesn't get back 500 cc's every 12 seconds, the machine takes a breath for the patient. It breathes for the patient. That's why it's synchronized, intermittent, mandatory. So if a patient breathes on their own, the machine does nothing. It realizes, I sent in 500, the patient inspired, there was a break in the loop, and then a few seconds later 500 came out. The machine goes, perfect, doesn't need me. I'm just sending oxygen through. I'm just giving you oxygen. I'm not helping you breathe. If, however, the patient doesn't breathe, stops breathing for a minute, the vent will deliver a breath. Uh-oh, I haven't been interrupted, I need to deliver a breath. If the patient starts to breathe and it's not enough tidal volume, the machine will help it. It'll give it pressure or volume support. So essentially, the patient has all the trigger in SIMV. If you're breathing, not enough, the vent helps you. If you're not breathing deep enough, the machine helps you. If you're not drawing in enough, strong enough, the machine helps you. Okay? So AC, the machine does everything. You change everything on that machine. You set the respiratory rate, the tidal volume, the PEEP, the everything. IE ratio, all that. SIMV, you find a target. You find a respiratory rate and a target. Much different. So patient who's anaphylactic, who can breathe on their own, they might just need airway protection. The machine may never give them a breath. Okay. Then you have pressure control and pressure support. Those are the other ones that you'll see a lot. And that literally is the same thing as SIMV, except you're just picking one thing. You're picking pressure or volume. The patient's not breathing deep enough or not breathing strong enough. Now you don't set a respiratory rate. So what will happen is the patient will breathe, and the patient won't breathe, and the patient won't breathe. So some machines have an apnea time. If it doesn't sense a breath every 20 seconds, right, that'd be 5 a minute or 6 a minute, then it will breathe for the patient. Not all machines have an apnea time. So these modes are not used a lot because we're intubating somebody, we've given them drugs to sedate them and intubate them. And if we're not watching, they go apneic, and they don't get a breath because they're not breathing. So these modes only help you with your breath. They don't give you breaths unless you set apnea time. So they just give you some background pressure or background volume. All right, so you have your trigger, the patient or you. You got to decide who triggers the vent. Now your target, volume or pressure. Now we can go into some of Pascal's law and all those stupid laws about ideal gases and volumes and pressures, and I don't care. All you need to know is they both, AC and SIMV, have a pressure control and a volume control. You can set both. AC, you have to set the volume control. And for most patients, we worry about volume more than pressure. We'll talk about pressure in a minute, but we've always talked that between 8 and 12 cc's per kilogram of ideal body weight, not your true body weight, so yeah, don't overventilate me, I'm big. Remember how you find ideal body weight? Yeah? Want to know the formula for it? Neither do I look it up. But we know that lungs are the same. If you're 6'2", everybody with 6'2" has about the same lungs. Whether you're 120 pounds or 450 pounds, your lungs are basically the same. So that's why we use ideal body weight. So the lungs don't change much. So we always used 8 to 12 cc's. We'll talk about in ARDS, there was a huge collaboration called the ARDSnet that did a lot of work on this. And we'll talk about that in the ARDS lecture, but they're using 4 to 8 cc's, so way below what we've traditionally used, and getting better results. We'll talk about why. And then you want to measure the plateau pressure. So what is the pressure? Where it's a closed system, you go down, all the way down, and then you get the alveoli. So you have two pressures, and we'll talk about that. We have a peak and a plateau. When that machine blows air in, what is it blowing? What is the resistance it meets? Versus the plateau. After I've started my breath, what does it take to keep it open? Okay? Imagine blowing up a balloon. What's the hardest part of blowing a balloon up? That start, right? Getting it open. That's the peak pressure. Now, peak pressure can change for a lot of things. If you have bad asthma, that's your airways that are causing the problem. If you have a mucus plug in the tube, the endotracheal tube, that's got to push against that. That's a problem with peak pressure. It's the pressure getting the air in. Once it gets through the swelling of the upper airway in croup or asthma, or the swelling of the lower airway and bronchiolitis, once it gets through that, the alveoli doesn't need much pressure to get open. In ARDS, where you've got an alveolus full of fluid, it actually takes more pressure. You have no upper airway problems. You have more pressure down the alveolus. So what we do is, the machine will always give you a peak pressure, and you'll get a million alarms on peak pressure, peak pressure. You want less than 30 ideally, less than 35 ideally, around 30, hopefully 20. So this is all those things that cause resistance. The person's got stiff lungs like COPD, or they're 600 pounds and they just can't get their chest rising. It's all those things that influence that. The plateau pressure is not given to you on the machine ever. You have to hold this button that says hold. You hold the hold button while they're breathing, while they're inspiring. So If your breath is just constantly going in and you hold it open, the system open, it'll equilibrate. The whole system will equilibrate. That's your plateau pressure. That's far more important than your peak pressure. It's like I said, you could have a clog in the endotracheal tube. I could have a kink in the ventilator system. That's all going to raise my peak pressure. But the pressure that's getting in the lung is not much. So I want to know, after I get past that kink or that plug, what is my actual pressure in the system? That's a plateau pressure. And you just hold the hold button. It's really, really simple. That's the pressure we care much more about. So this is a really bad graph from an old journal that I tried to scan in. Can't really see very well, but you can see where a normal patient is. They get a peak, they drop off to a plateau, and they come back for expiration. People with the high airway pressure have a high peak pressure, that's asthma, stiff lungs, tube kinking. Then it drops off to a normal plateau pressure. Once you overcome whatever resistance it is, your plateau pressure is much better. What we talked about, if you have a high pressure, your machine could be screwed up, your circuit could be screwed up. They have a little water filter on them to make sure that the patient gets moist air. Those get clogged, they get full of water, people get mucus. Or it could be the person, right? They're getting bronchospasm. Talked about all those. So the first thing you do, you get this plateau pressure that's 60. It's like, oh my God, I'm going to blow this guy's lungs out. His head's going to come off. Take off the ventilator and just put a bag on him. Bag him. If you can't bag them, that's a real pressure, which you'll see. You get an ARDS patient, you're like, trying to squeeze air in. If you go in there and it's like, it's fine. So the first thing we always do is disconnect the vent. Take that piece of machinery that's hard to operate out and just go back to the old school. And another way to tell is, so measure the peak and the plateau. If the peak is really high and the plateau is normal, you've got a problem before the person, your tubing, your machine. If they're both high, you've got a problem with the lung, ARDS, things like that. Okay, after it's equilibrated, you've got a problem. All right. So the system terminates once they've gotten the prescribed amount of volume, or in the pressure modes once they've reached a certain pressure. Not a big deal. All right, here we go. Time to put on your thinking caps. You have a 36-year-old brought in by ambulance, drowsy and obtunded. No history. The roommate called when she got home and found the patient on the floor. So EMS brings him in. The presenting vitals are 155 or 90. Heart rate is 120. Respirations are 6. SpO2 is 88. You put them on oxygen on a 15-liter non-rebreather mask, and they go up to 100%. And their temperature is 38, which is what? There's certain temperatures you have to know in medicine. 37, 38, 39. 37 is normal. 38 is a fever. 100.4. So if you're doing little kids, 38 is bad. Well, it's not bad, but it's got to be worked up. And 39 is 102. So the patient is 100.4. Yeah. The pupils are midriotic, sluggish to light. The skin and mucous membranes are slightly dry. She's got almost no bowel sounds. You can wake her up only by doing a sternal rub, pinching her fingertips, those kind of things, but doesn't communicate at all. She will move a little bit, and there's no sign of emesis on her. She doesn't have dry throw up on her. She's not incontinent like after a seizure. Paramedics gave Narcan, which is for what?
Overdose.
Opiate overdose, right? Opiate overdose. No change at all. So doesn't start respiring more, doesn't wake up. So what is this? What's the problem with this patient? Without looking ahead.
I check a blood sugar.
Okay? Always check a blood sugar. Like first thing the ultrasound says, check a blood sugar. It's normal. What else?
Some type of drug that's not.
Some type of drug. Have you guys had any toxicology? Toxidromes? Okay, all right. So this is a toxidrome. This is a hot as a hair, red as a beet. Okay. All right. It is most likely anticholinergic. You took a handful of Benadryl or Tylenol PM or one of the anticholinergic drugs. Maybe a mixed ingestion. But this is your typical anticholinergic overdose. And these are all cases that I've seen in the past few months. Okay. So anticholinergic overdose, you know what you give for it? Isostigmine. Okay. Doesn't respond to it very well. It's probably a mixed ingestion. So they need help. She's still breathing 6 times a minute. She rouses to painful stimuli, but she just needs a little bit of help. So these patients, I don't have to knock her out. I don't have to completely paralyze her. I can put her on SIMV so that she's making the choice. I set it on 10 breaths a minute. If she doesn't breathe 10 times a minute, she gets those other 4 breaths, because she was at 6. I give her a target of like 8 to 10 cc's of tidal volume, and some PEEP to keep her airways open. So that's SIMV. That's pretty easy. All right, now this gets better. 42-year-old working in the field when he was stung by an unknown insect. He's got a history of Hymenoptera allergies. He's always been mild. Hymenoptera is what? Bees,
Wasps.
wasps,
Ants.
ants, right? So people often have cross reactions to these kind of things. Somebody took zoology. So after 20 minutes of being stung, he begins to feel really dizzy and lightheaded, and he begins to get this generalized urticarial rash. So he drives himself to the ED because everybody does when they're feeling dizzy and lightheaded. He gets here in about 15 minutes, and he's dizzy, lightheaded, near syncopal. He stands up, and he almost passes out. And his voice is coarse. His wife says this is not his normal voice. His throat itches, his tongue feels swollen. He's a little hypotensive and tachycardic. He's a little tachypnic. His sats are okay, and his temperature's okay. He's clammy. He's got a lot of wheals, urticarial patches. His voice is near stridorous, and the rest of his exam is essentially unremarkable. So this is what?
Anaphylaxis.
Anaphylaxis. The definition of anaphylaxis is what? Okay, so it's cardiovascular or cardiopulmonary compromise in the presence of an offending allergen. So I think we've really undertreated, and I know we have because this has been some big journal articles, we've really undertreated anaphylaxis. We've just called things allergic reactions. But this guy has cardiopulmonary collapse in the presence of a known allergen. So this is anaphylaxis. So, without going ahead, what are you going to put him on? Yeah, he's stridorous, his airway's getting swollen. And what vent settings are you going to use? Just off the top of your head. SIMV, right? He's still breathing, he just has upper airway swelling. All right? So this is a great case. Here's the rest of it. We gave him IM, Epi, we gave him Benadryl, everything, and he just kept swelling up. So he finally got intubated. So we even gave him an Epi drip, and he still wasn't. And his vocal cords were all swollen. I barely got a tube in. And then I went and changed my pants afterwards because, jeez. People with anaphylaxis, it sucks, man. Especially if they're on an Epi drip, their airway gets small. It's hard to put a tube in. Yeah, ketamine?
Yeah.
He was intubated with ketamine.
Oh.
He was given ketamine and rocuronium. So what's good about ketamine in this situation?
Bronchodilates.
It's a bronchodilator, and so ketamine doesn't depress your cardiopulmonary function. So that's why we give it in procedural sedation. We give it to kiddos we're doing LPs on or LAC repairs on. They still breathe. Ketamine sedates you and dissociates you, right? What is ketamine most like that people like out in the drug world? Ketamine is PCP, right? It causes this it's one molecule different from PCP. It causes this nice dissociative state. You don't know you're there, your body's there, your mind's here. It's great until you wake up and try and put them back together. It's called an emergence reaction. It's awesome to watch. It sucks for the patient. They come out of this and they are freaked out because all of a sudden their mind and their body are together and they go crazy. I mean, they absolutely, yeah. So give them something else. So give them a little benzo with it. So I used ketamine to keep him awake and breathing. And then right before I put the tube in, I gave him a little bit of rocuronium, which is a short-acting paralytic, so I could pass the tube. And then he woke up, and he was on AC first while the paralytic was in there. And then as the paralytic went off, because he wasn't breathing with the paralytic, I put him on to SIMV. Yeah. Okay. So this gets a little more complicated. A 78-year-old with diabetes, hypertension, hypertension, and COPD. It's all the same, right? It's an old person. It's an old person. 4 days of literally what we call ADR, ain't doing right, that's what she said. I just don't feel good. So diagnosed with ADR. Fever, chills, weakness, tired, hadn't got out of bed, hadn't eaten, all that kind of stuff. So she's hypotensive, she's tachycardic, she's tachypnic, she's hypoxic. It does come up with 2 liters. And she's got a fever of 39, which is 102, right? 37, 38, 39. If you can remember those three numbers, it's really simple. You're not sick, you're a little sick, you're sick. So she's pairs normal, she's in low respiratory stress, she's leaning forward. Her chest, she's decreased overall, she's got some wheezes, some bronchi in the middle lobes. She's using accessory muscles, right? She's using those sternoclavicular muscles. She's got intercostal retractions, subcostal retractions. But she's got no peripheral, what is CC? Sorry, I just don't want to take the whole slide. So back up on CV, what is that? CV with TAC, but no murmurs, rubs, or gallops. And peripheral exam shows no cyanosis, clubbing, or edema. So that's what that is. So what's your diagnosis?
An exacerbation?
Exacerbation of COPD. What else? So she meets the criteria for sepsis. Have you done sepsis yet? Like the biggest killer right now? Yeah, I mean, sepsis is terrible. So she meets the diagnosis of sepsis. She's got multiple inflammatory markers. She's hypotensive, she's tachycardic, she's febrile. So sepsis from COPD, from a new pneumonia. Did you think she has CHF?
Did she have edema?
She's got no edema, right? She could have an acute myocardial infarction that's causing the right ventricle to fail, left ventricle to fail. Could be poisoning in a 74-year-old who likes recreational drugs, I don't know. So you get labs back, and her CBC's got a white count of 23,000. It's all segs, it's all neutrophils. So normal white count's up to about 10 or 11, so she's way above that. Her chemistry, she's got a CO2 of 12. So what do you, I gave you the APG already. So I was gonna say, what do you think she is? She's acidotic, pH of 7.11. Okay? And she's got an anion gap of 20. Most of that's probably due to lactic acid. PaO2 is 60, and PaCO2 is 20. So what should your PaO2 be about? 80. Arterial oxygen should be about 80, give or take, especially on room air. Her PaCO2 is 20. What should that be? 35 to 45, somewhere in there. And her SaO2 is 86, so it's lower than actual that's measured by the finger probe. Okay, base excess is negative 6. I don't know, I never use that, sorry. So what are you going to do with this lady? She's 74 years old, she's hypotensive, she's tachycardic, she's febrile. This has been going on for 4 days. So I'm going to tube this person because they're getting tired. She's using her intercostal muscles, her supraclavicular muscles. She's got substernal retractions. She's going to get tired really quick at 74 years old. She's sick. She's acidotic. She's trying to breathe faster. So this is somebody that you want to paralyze and take away that oxygen demand, that extra oxygen demand of having to breathe, and extra work of having to breathe. So she gets assist control. She gets knocked down, she gets kept paralyzed, and we're going to intubate her with assist control. So the patient was breathing how many times a minute? 24, and her pH was what? 7.1, she's acidic. The heart does not like to be acidic, right? So one of the things you'll find out is the heart stops when it gets too acidic. You get to 6.5, 6.6, 6.7. You get this asystolic arrest because of the because you have metabolic acidosis or respiratory acidosis, and it's very hard to restart the heart. So we put her on. She's 7.11 at 24 times a minute. The ventilator, you normally start people between 12 and 16, even 20. What happens if I start her at 14? I put her on the ventilator. I'm taking over breathing. She's been breathing 24 times a minute, and she's 7.11. What's going to happen when she goes to 12 respirations a minute?
She's going to become more acidic.
Right. She's going to become more acidic. In emergency medicine, this is one of the times you can do what's called a clean kill if you don't like somebody. This happens not infrequently. Aspirin overdoses, severe sepsis, severe acidemia. The ventilator comes set up at 12. 500 cc's, 12, 5 of PEEP. That's how it comes set up. You have to make the changes yourself. So the RT, the respirator therapist say, hey, what's the usual settings? And in this case, if you say yes, you're gonna have a pretty clean kill here, not in a couple minutes. Because she is breathing fast to get rid of that CO2, and she's doing